Hello, and welcome to the Postpartum Years podcast. I am your host, Dr. Ellen Kramp. I am a physical therapist and a pelvic health specialist. Today, I'm going to be talking about antibiotics. You might be wondering, okay, it's a postpartum podcast. Why are you talking about antibiotics? Well, during birth or not too far after birth, a lot of women end up receiving antibiotics for one reason or another. If you've had a C-section, chances are you received antibiotics, either leading up to the C-section or during that C-section and just afterwards. So there's a lot of use of antibiotics that go kind of unknown to the women who are receiving them. Yeah. So you may have received them whether you know it or not. And then there are also other issues where women come across different problems where they'll receive antibiotics. One of the problems is mastitis. So women who have mastitis might be receiving antibiotics. So C-section, there can be infections after delivery as well, where antibiotics will be necessary, and mastitis. So I have an expert here in prescribing antibiotics. My husband, Matt, Dr. Matthew Kramp, is a physician. He is board certified in internal medicine and emergency medicine. And he will be bringing us through what antibiotics are, why we use them, and what problems can be created because of antibiotics, and what other problems that they can solve. With a quick rundown of the microbiome, we normally have bacteria in our systems. We have viruses that are normally in our systems as well, fungi, et cetera, et cetera. That's just a normal part of our biology. So I know we have about 10 trillion cells-ish in our body, and most of those are not human.
Yeah, somebody did a study recently, and I can't attest as to the veracity of it, but supposedly for every one of our cells, there are 9 bacteria in us and on us, and yeah, that it kind of reorders, what we are. I mean, are we just a big bag of bacteria that's using a human to get around, or vice versa? So it depends on how you choose to look at it.
So if we are like mostly bacteria and viruses and such, um, why are we constantly needing antibiotics?
That's a large question with I guess I can oversimplify an answer. The fact is that, yeah, if we don't use antibiotics unless we're having a problem. Uh, we call a problem that's due to microbes an infection, and that really is about as narrowly as you can define the term infection. Uh, yeah, it's kind of like, what's a weed? It's a plant that's in a place where you don't want it to be at a time where you don't want it. And it's the same thing with an infection. It's kind of a bacterium that's having effects in a place where we don't want it at a time when we don't want it. And then we use an antibiotic, which, the more we look at this, the more we're realizing that, it's using a shotgun to kill a mosquito in many cases, where we're just using a particular chemical that has activity against a wide variety of bacteria to solve a very narrow problem. But that's what we have, and let's face it, it's been a wonderful thing for our survival as well as a species and individuals when we invented penicillin. Since then, our lifespan has increased, and we've been able to deal with a lot of our problems quite effectively. But we're getting to the point now where we're starting to recognize that it's not the ideal answer to every situation.
Can you explain how, like, why would you choose a certain antibiotic? Some antibiotics eh, will kill like a much larger variety of bacteria, and other antibiotics will kill just a certain variety of bacteria. So, can you explain the difference between the different types?
Well, what you're talking about is the difference between broad spectrum that kill a large number of bacteria and then narrow spectrum, which kill a small number of bacteria. What we try to do as physicians is try to pick an antibiotic that will fix the problem that we're dealing with a minimum of side effects and a minimum of effect on other bacteria that don't require, I guess in this case, eradication, that don't require dealing with. That kind of leads to a question of, well, how do we figure that out and how do we adjust that? And that's because bacteria, of course, there's innumerable different kinds and strains, et cetera. We've all heard about the different strains of the COVID virus, and that same issue can apply to bacteria as well. There are different types of bacteria. We break them down into some broad classifications. Some of you might have heard the term gram positive versus gram negative. There was, of course, a man who invented a staining technique years ago, and we apply that. Well, we used to identify bacteria, and we sometimes still do by this staining technique. What gram positive bacteria take up a stain in one way, and then gram negatives don't take up that stain when we apply this process. And who cares what color they look like or what color they stain? Well, those stains are specifically designed to be an indicator of the structure of the cell wall of the bacterium. So a lot of antibiotics act on the cell wall. If you remember way back to junior high or high school biology, part of the structure of many cells is that they have a wall. There are several antibiotics that act on a microbe and make it vulnerable by disrupting the process of it making a cell wall. And if a bacterium is gram positive, some antibiotics will affect it. If a bacteria is gram negative, other antibiotics will affect it. And there are a lot of other factors within an organism and a lot of different ways of classifying different bacteria that don't just depend on the cell wall, they also depend on how they reproduce, et cetera. But bacteria they are different from each other in a lot of structural ways. And because antibiotics attack a structural vulnerability, it helps us to know what that structure is. And it helps us to classify these microbes in that structural way. So the way we decide on which antibiotic to use is we know, this is where, it gets beyond the PhD science and becomes things that physicians learn. We start to understand what types of bacteria cause certain types of infections. So for the most part, for example, skin infections are caused by gram-positive bacteria. So if somebody has an infection called a cellulitis, or for that matter, we can get into mastitis a little bit as well. But those infections tend to be caused by gram-positive bacteria. So we use antibiotics that can eradicate gram-positive bacteria. As to juxtapose that, gram-negative bacteria tend to cause infections, well, specifically urinary tract infections are often caused by gram-negative bacteria. So we tend to use antibiotics that are more effective against gram-negative bacteria in order to treat those infections. So the reason why we choose an antibiotic is partially related to what organism is most likely to be causing that infection.
So if, a woman where UTIs are very common after or in the postpartum period, those that have had prolapse or anything like that, changes with lactation, UTIs can be more common because there's a change in pH. Um, Using an antibiotic that they had been given for mastitis is not going to be the same one that's going to help them with that UTI, is what you're saying.
Probably not. I mean, there are some instances in which I've had some difficulty treating patients that have two different kinds of infections, say a sore throat and a UTI. Okay, I don't want to give somebody two different kinds of antibiotics if we can avoid it, but okay, now I've got to try and figure out, okay, so what's going to kill strep and also probably E. coli, which is the most common cause of bladder infections. So there's a very limited number of antibiotics that can be applied to that situation. But that's, again, that's kind of where the being a physician part comes up to, just trying to take knowledge from different fields and use that information to deal with something in a practical way.
And at the same time, not use something that's going to kill, like, you know, way too much within a person's system and throw a lot of other things out of balance.
Right. I mean, now we start talking about the how antibiotics affect our microbiome. Uh, like we said earlier, there are a lot of bacteria within us, and a lot of those bacteria perform helpful functions. We're just scratching the surface of what these bacteria actually do for us. But we have noticed that if we put somebody on too many antibiotics, it can cause various deleterious effects. Some people get yeast infections, others end up with a diarrhea. Some people end up with fairly nasty kind of diarrhea called C. diff, is I guess the popularly known name of Clostridium difficile, which is a particular type of bacteria that's rather difficult to kill with most antibiotics. And if we wipe out a lot of the bacteria's regular flora, then there lies not only physical but ecological nutritional space for this bacteria to kind of overrun the colon and cause rather dangerous diarrhea. And almost like a locust, when there's too much of it, it changes its behavior a little bit and starts producing a toxin, and this makes it very dangerous. We try to avoid producing that situation. We try to avoid using too many antibiotics, wiping out all these bacteria that are trying to help us so they can continue to take up space and keep this Clostridium difficile at bay, or keep C. diff from developing. So, yeah, there are advantages and disadvantages to using antibiotics, and we also need to try and limit the limit the amount of collateral damage, I suppose would be a way to put it. When we do try and go after something that's causing an infection, we want to try and target our treatment to the organism most likely to be causing that problem, and try to not cause harm to the others that are trying to help us, or at the very least that are getting in the way of those that are trying to harm us.
Yeah, along that same vein, with women who are postpartums, particularly the ones that have had C-sections, they're at much higher risk for developing a yeast infection of the breast and for the baby developing thrush. So do you want to explain kind of that that side effect that happens?
Well, I mean, to look at it in a somewhat simplistic way, the theory is that when you've been placed on antibiotics, or for that matter, when antibiotics end up getting into the system of the neonate or the baby, uh, then again we worry about that getting rid of the normal bacteria flora that are in a place. And while I used Clostridium difficile or C. diff as the example of why we don't want to uh, treat bacteria that aren't causing a problem, the same issue applies to yeast, also known as Candida, or Candida albicans, to use the full name. But Candida also tends to take a foothold in areas that are wet, and or that tend to stay damp, and where there's normally a fair number of bacteria. And if we get rid of those bacteria, or enough of them, then the yeast is allowed to start growing and starts to get invasive and grow into our tissue, grow into our mucous membranes. And that's when we have something like thrush in the baby's mouth commonly, or for that matter, the vaginal yeast infection that so many women have to deal with after antibiotics. So, yeah, there is a role that antibiotics have to play in that developing. And I can't state this with, I don't have numbers to back this up, but I think it's kind of common knowledge that women who end up getting C-sections tend to get more antibiotics. And also, we tend to be concerned about things like endometritis and infection that develops within the uterus. So we tend to use broad spectrum antibiotics, and because it would make sense that if that is the case, then yeah, we have again more antibiotics in the mother baby system, and you're going to be more likely to develop a yeast infection. That stands to reason. Although one thing I would want to add, and I don't think even we've talked about this over the dinner table yet, but I was talking with a colleague recently, and uh, I think they were also discussing a case with an OBGYN as to whether or not a mother who had a vaginal birth would likely have received antibiotics, and they said almost certainly. They
Hmm.
don't make a big deal of it. They don't tell everybody, but yeah, most women, even going in for a vaginal birth these days, tend to get antibiotics just prophylactically. There's a lot of facets and a lot of moving parts to what we consider to be good antibiotic stewardship. And again, I'm not an OBGYN and I haven't had a whole lot of time to look into this, but I'm not sure as to why this is done, but it seems to be a general practice among people whom I know to be aware of the importance of antibiotic stewardship. And I would expect that they do have a good reason for doing this. Typically, I mean, we get prophylactic antibiotics to reduce the likelihood of in childbirth, the context was we worry about bacteria seeding in other places. Quite often we think about bacteria settling in an artificial joint. And well, okay, so how many pregnant women have an artificial joint? Well, that's one of the most common places an infection can start from just bacteria that ends up in the bloodstream during some sort of a traumatic event like childbirth, or for that matter, everybody knows about getting dental work, and then we end up getting some bacteria in your bloodstream, and we don't want that bacteria to end up settling anywhere like an artificial joint. There are other concerns like discs in the back, heart valves, other places bacteria can end up and cause problems when they end up in the bloodstream, even for a short period of time. So it was the context of this discussion was that to avoid that kind of seeding was the reason they were given antibiotics, even for a vaginal birth.
Okay. When I had done research, I had looked through and found the World Health Organization guidelines, the American College of Obstetricians and Gynecologists guidelines, and also the UK guidelines. And there were two places in the UK that had specific guidelines. All of them talked about all all women 60 minutes prior to a C-section or as soon as possible, um, as a C-section started, were to receive antibiotics to prevent infection. If a woman had a premature rupture of membrane, so if the water broke too early, they also received antibiotics. If they were high risk for cardiac issues, they receive antibiotics. If there is a retained placenta at all, those women also receive antibiotics. If there's a third or fourth degree perineal tear, those women receive antibiotics. And then there's also that population, they're tested for group B strep. All of those receive antibiotics. So there's a huge percentage of people who are going to be receiving antibiotics, even if the OBs stick to just those categories. That's a pretty broad range.
And those are even the official recommendations and considered to be the minimum standard.
Right.
There sometimes at the discretion of the physician, there are other reasons to do that as well.
Yeah. You were bringing up antibiotic stewardship. This was something also that the Academy of Breastfeeding Medicine was really proposing. In 2022, they had new guidelines for mastitis. So it used to be mastitis if it had been going on for 24 hours, more than 24 hours, give antibiotics. That's no longer the case. They're looking at, is it inflammatory or is it infectious? And so one thing that we had been discussing is, when does it look infectious? And, somebody has had surgery, looking at that surgical site, it's usually red. It's inflamed, but it's not infected. But then when it gets infected, it's kind of like, ugh. And that person could start to be developing a fever, and it could, start um, having other symptoms as well. So the pain may be escalating, they may be having a fever, and according to the Academy of Breastfeeding Medicine, reserving antibiotics for those situations where um, the breast is actually infected versus just having some inflammation, where that woman could be using an ice pack to calm things down, feeding regularly or pumping regularly to calm the breast down. Um, but yeah, in general, using antibiotics in a more sparing manner, if possible, is definitely the recommendations. Although I think in the obstetric world, it's probably not as easy as that sometimes.
Yeah, well, and there's also, and we've had conversations about this in the past. There's a difference in the way the primary care physician would approach this as opposed to the emergency room doctor. And we have talked about, is it a good idea to go to the emergency room for this, or should you go see your primary? And again, it kind of relates to, well, how quickly can you see your primary care doctor as opposed to, the ER is always there. The problem is that, well, there's not to badmouth the ER, but I think a lot of people don't understand that our perspective in the emergency room is to fix anything that could kill you in the next 2 or 3 days or less, and anything beyond that, well, if it's quick and simple, yeah, we're happy to help out. But the thing is, for other issues, mastitis in particular, for one, we're not particularly well trained as to how to deal with any real I guess any real subtleties in treatment or diagnosis with mastitis. Most ER physicians look at a breast that looks like it's red and inflamed, and it's hard to tell inflammation from infection. As I've said to you earlier, it's like I couldn't tell you if it's inflamed or infected. They look the same to me. And they really do. I mean, I can look at wounds. I've been doing this for easily long enough. I can tell you if a wound looks infected or is it just a little irritated. That's an easy thing for me to differentiate. But to say that, well, there's a breast that's a bit red, a bit what we call indurated, where the tissues have more fluid in them and the tissue feels firm. And if it's a bit red and tender, it's hard for me to say whether it's infected or just inflamed. And the easy way out for the emergency room doctor, because we don't want to miss an infection, we don't want things to get worse, we're just going to put you on antibiotics. That said, I've also done primary care. And the luxury that I have in primary care is I can tell somebody to come back tomorrow. I will be there tomorrow and I will see them, and we can get an idea as to one day to the next what direction these things are heading, which gives me a lot more security and a much better perspective on the problem. So I could be a lot more, I guess, I could be a lot more careful about using antibiotics. I can feel a lot safer not giving somebody antibiotics to begin with, and let's see how things evolve down the road and see if you really need them. So the treatment ends up being different depending on where you see me and under what circumstances I would be seeing the patient.
Hmm.
So, and there, you would think that all doctors treat everybody the same if we just knew the right way to do it, and a lot of these things end up being situational. So, I guess the lesson that comes out of that is if you possibly can, see your primary doctor about this, and if you have to go to the emergency room, understand that we'll be happy to take care of it, but we kind of assume the worst, and we try to guard against that.
One thing I know that I have heard from so many patients, and so many people in general, that they don't understand the difference between IV antibiotics and oral antibiotics, and they assume that IV antibiotics are better.
Well, and
Go.
here we go to one of my peeves, one of our frustrations. Um, yeah, in reality, it's not. I mean, there's not really that much of a difference between IV and pill antibiotics. People for so long, doctors have said, "Oh, you need to go to the hospital where they can give you IV antibiotics because they're so much better than the ones I can prescribe you," and that's not necessarily the case. There are some, as a matter of fact, there are a lot of antibiotics that are given by pill that are also given by vein. It's the same antibiotic. The only difference is it takes effect about 45 minutes to an hour later. There are a few cases in which that that time difference has been shown to matter. One is meningitis, and actually there are two different medications that are given for meningitis, neither of which are well absorbed in pill form. So that's one difference. Many of the medications that we do give intravenously are given in that way because they cannot be given in pill form. Vancomycin, for one example, is given almost exclusively intravenously because, with one exception, any infection that's treated with vancomycin, we need to get it into the bloodstream, and your body will not put it in the bloodstream. That said, for C. diff or Clostridium difficile, vancomycin is one of the most effective antibiotics we have, and we give it in pill form because we want it to stay in the gut, because your body will not absorb any of it into, into circulation. So we want it to stay in the intestines, in the colon, where the problem lies. And for years, this antibiotic in pill form was insanely expensive because we needed so little of it that factories couldn't operate in it for any period of time making these pills. Just every once in a while, they would run on a small scale, which again is ridiculously expensive. There were limited production runs. There was no economy of scale, so the pills were ridiculously expensive to make. Vancomycin itself is actually fairly cheap, but to put it into a pill with any reliable
Oh, wow.
quality, yeah. So I mean, there, and it's funny how business cases and economics factor into all of these issues as well. There was a patient that I had the other day. She was complaining that doxycycline was burning going into her arm because it was being prescribed intravenously. And I think it was just a knee-jerk reaction from one of our hospital staff to give her everything intravenously because that's what they do for this problem. But with this patient, there was no reason she couldn't take a pill. So she refused to any more of the IV doxycycline. I said, well, okay, just give it to her in pill form. It'll work just as well. It gets absorbed quite nicely through the gut. It'll get into circulation, and the problem that you're trying to treat, we treat all the time in pill form. So yeah, it even comes down to the individual medications sometimes as to why it's given in a certain form. But as a rule, intravenous antibiotics aren't necessarily better because they're intravenous. The thing that makes the difference as to the decision as to whether or not a patient needs to be in the hospital versus can go home is, can the antibiotic that they need be given in pill form? If it can, they can go home. If not, they probably need to be in the hospital. Also, there are some rather broad spectrum medications. Some of the new broader spectrum antibiotics really can't be absorbed by mouth in the doses that we need to give. So that's why a lot of patients who need to be hospitalized also end up on intravenous antibiotics, because they have a problem that either we've tried to use pills and those pills, the problem has proven to be resistant to those pills. So we need to try something different, which in this case ends up being an IV antibiotic. So it's kind of a chicken and the egg thing sometimes as well. It's like, either are they in the hospital because they need IV antibiotics, or are they sick to the point where they need to be in the hospital, and that's why we're using the IV antibiotics. So yeah, again, so many of the questions that you ask do not have simple answers, and I'm sorry. But
I know. I know it's not a simple topic. It seems
yeah,
like it
but
would be,
and it
but it's
really
not.
isn't, and it really isn't a simple statement to say, well, IV antibiotics are stronger than those given by mouth. There was a killer antibiotic pill that was out years ago. It would kill darn near anything except for the patient. The only problem is it also is the way we figured out that one class of antibiotics can cause tendons to snap. So it
Oops.
did that to a few people. I was aware of early on 10 different cases of Achilles tendon rupture, that thing that allows you to stand on your tiptoes. Those tendons would snap, and it was linked to that antibiotic. But this thing killed gram positive, gram negative. There were, aerobes, anaerobes, basically bacteria that required oxygen and those that thrived without oxygen. Almost every bacteria out there that we treated for that was a human pathogen was killed by this antibiotic, and it worked great. I loved what it did for some of my patients, but yeah, it proved to be too much of a problem. So we had to take it off the market. But it was a pill, and it was a kick butt pill.
We are now back together in one screen. And so we are going to now discuss the use of antibiotics for a virus, which, hint, shouldn't be done.
Yeah. Spoiler alert. Yeah. No, it's a common thing that a question I was getting when I was doing primary care is that patient, or even for that matter in the emergency department, I still get where patients come in and they have the classic runny nose, possibly even a little bit of a sore throat, a mild cough, and frequently a fever. And this has been going on for 2 or 3 days. They're sick of dealing with it. And quite often they're about to get onto an airplane the next day and they want me to fix this. And well, there's an old saying that goes back a long ways. There's no cure for the common cold. And that's still the case. These are viral infections almost universally, especially when you get the runny nose, the sore throat, the cough. There's bacterial infections tend to be a little bit more limited geographically. They tend to infect one organ system or one particular site. Viral infections, on the other hand, you tend to get the generalized malaise and kind of just a system-wide effect, like the entire respiratory tract gets affected, that kind of thing. And the reason why we don't give antibiotics for this is viruses are fundamentally different from bacteria. Just as I was saying, one type of bacteria is different from another and requires a different antibiotic. Viruses are a different thing altogether. Antibiotics flat out don't work for viruses. It's because they're very different in the way they're put together and the way they operate. Bacteria, on the one hand, have all the machinery within them that they need to survive on their own for the most part. Sometimes they do require a certain an environment or something like that, but a virus, almost by definition, can't survive outside of its host cell. Or it can survive outside of it, but it can't reproduce, it can't grow, it can't carry on normal metabolic activities. It becomes dormant unless it's within its host cell. It has to use another organism's machinery to accomplish most of the functions that we would associate with life. And that would be a whole different video altogether, but not for today. The thing is, there are some antiviral medications that we have come up with. There are some that work for, and they work for a specific virus typically. There is medication that suppresses the reproduction of COVID. There are medications, several of them, that suppress the replication of HIV. There are some that we have been able to put together a combination of medications to eradicate hepatitis C, if I remember correctly. But for the most part, we don't have real treatment for viruses, and we can't make them go away. And the problem with upper respiratory infections is they're caused by 60-some different strains of different types of viruses, and there's even variation. And just like there are subtypes of different strains of COVID, there are different subtypes and strains of all these different bacteria. That's why we don't even have tests for them, because it's not worth doing the testing for them. The good news with viral infections is that they go away in a matter of a week or two, and the bad news is that there's not much I can do to make that happen any faster. So we generally recommend treatment for symptoms for these kinds of things. But that, and there was also the other issue of patients who come to my office or to the emergency room and say, well, my doctor gave me antibiotics last time I had this, and 2 days later I was all better. Well, again, this gets back to how science is done. We do studies that, when we do this study, we take people, preferably who have an infection in this case, and we separate them in half. We assign them randomly to one group or another, and we do it without telling them, or for that matter, their physicians, which medication they're going to get. They either get a sugar pill or they get the medication that we're investigating. And when we compare those groups, after all is said and done, the reality is that the antibiotic group is no different from the sugar pill. If you got better 2 days after your doctor gave you an antibiotic, you were going to get better 2 days later anyway, even without the antibiotic. And that's really hard to explain to people, and I understand that, and I understand the emotions that go along with that, and you just want to feel better. And I wish I could help with that. The reality is that we're better off not giving antibiotics because they do cause problems that we've discussed earlier, and they're not going to help a virus. So I guess that gets us a bit off the topic of breastfeeding and mastitis, but well, I suppose I use any chance I get to try and spread the word as to why we do what we do.
All right. So do you want to summarize antibiotic usage, when it can be used, when it can't? And
well, again, there's a reason that antibiotics are available by prescription. And there's a reason why doctors go to school for all those years that we do, and have all the training that we do. It's not simple. I wish there was some overarching statement I could give as to, or I could make as to when antibiotics are appropriate and when they're not. And the bottom line, as it comes down to many times, is ask your doctor. It's really a matter of experience and judgment and knowledge as to whether or not you need an antibiotic, and if so, which one. Because these questions do matter, and sometimes it can be quite an important and consequential decision.
All right. So I think that sums it up for our antibiotics episode here. Thank you very much for joining us, and we'll see you next time.